My name is Todd Chassie, and I'm the Medical Director of Kent County EMS. I've been serving in that role since 2007, and I'm an emergency physician practicing in Kent County. I appreciate this opportunity. We've tried many times to answer the questions or the gray areas in the protocol. We've sent out emails, tried in-person educational sessions, and this is another attempt to try and reach our providers and provide answers to your questions and guidance to those more difficult cases that are not as black and white as the protocols are.
Today we're going to just review how to administer ketamine. First and foremost, you want to make sure your patient meets the criteria for ketamine. You're going to review your 6 rights of medication administration, and you're going to do a medication cross-check. First steps can be to determine your patient's weight and the correct dose. This patient weighs 220 pounds or 100 kilograms. You're going to check your medication, check the expiration date, and then hand it to your partner to do the same, cross-checking all of your R's, your medication, and your expiration. So if our patient weighs 220 pounds or 100 kilograms, our concentration that we have in the vial is 500 milligrams and 5 mLs, which will give us a dose of 20 milligrams or 0.2 mLs. To do this, we're going to use a 1 cc syringe. We're going to go ahead and drop the air to exchange in the vial. And then drop the appropriate amount of medication, which in this case would be 20 milligrams or 0.2 mLs. Now with ketamine, we need to make sure that we're diluting the medication to a 1-to-1 ratio. To do that, we're going to use normal saline. And again, it's a good idea to make sure you're cross-checking that with your partner as well. Correct medication and expiration date. So if we are drawing up 0.2 mLs of ketamine, we're going to match that at a 1-to-1. So we're going to add an additional 0.2 mLs of normal saline. And this will give us a total amount of volume of 0.4 mLs to administer to our patient. It's a good idea to remember too, when we're administering ketamine, that this is a slow IV push. Adverse reactions can occur when we push it too quickly, so this IV push is going to be slowly over 2 minutes.
I think that the way the protocol is written, it again identifies low levels of pain that the patient receives ketorolac or acetaminophen or ibuprofen, moderate amount of pain that the patient receives ketamine, and intense levels of pain that the patient receives fentanyl. I think that we need to think of the patient's overall self-assessment of pain with the Wong-Baker Pain Facies Scale, our assessment of physiology, what the patient appears to be experiencing, what we think the underlying mechanism is, and then come up with what their best choice of pain control would be. And for an elderly patient with severe pain, fentanyl, even low-dose fentanyl, might be a best choice. Ketamine might be an appropriate choice for a patient based on their underlying condition. A patient with intense pain where we think an underlying condition is renal colic or kidney stone may benefit from a first dose of ketorolac. And so, again, I would encourage our medics to use all of their assessment skills along with the protocol to come up with the best pain management option for that patient. There's a specific patient population where it seems that we have higher rates of adverse effects. That's specifically ketamine in the elderly populations. Some of the things that we found in patients over the age of 65, that these patients have had developed an oxygen requirement, and so a patient was not requiring oxygen, received ketamine at the appropriate subdissociative doses, but then required oxygen. Elderly patients who developed altered mental status required additional testing in the emergency department, such as a head CT, admission to the hospital. I think this has happened for a couple of reasons. The elderly are more susceptible to pain medications in general, and I think specifically to ketamine.